especially so since both of them have been partners in this work with us really from the beginning of this journey, and we look forward to hearing from them on their most recent successes in their work on this topic. But first, just a few housekeeping items I want to cover before we get started. To minimize feedback, please mute your line. If you are dialed in, please use your phone's mute feature. If you're using your computer only, click the microphone icon. If you're using both the phone and a computer, it's best to select the telephone option under Audio in the GoToWebinar window you can see on the screen, and then mute your phone. There'll be several opportunities for questions, so please submit them using the questions box of the GoToWebinar window. Before we launch into our webinar topic for today, we wanted to provide you just a few brief updates on the ACLC activities and some upcoming events. First, on the work groups, those of you who attended the recent summit held in Washington, D.C. May have attended the work group sessions we held as breakout groups. We're going to be taking the input from those discussions and incorporating that into our work group written materials. So you should be receiving those from the ACLC and the work groups. If you're interested in participating on any participating work group, in other words, if you're on one and you want to participate in another, or if you haven't been a participant and you want to participate, please contact us via email. Additionally, members will soon be receiving a survey to rank the ACLC competencies later this summer. As most of you know, and those of you who have been participating this year know, that our primary focus this year in the work groups has been on accountable care competencies. We're really looking forward to receiving your feedback from the survey on the competencies within a period of time that as soon as you can get them done, actually. We're going to plan to share our findings with you as soon as we get all the surveys back, so we encourage you to respond promptly. In terms of the next webinar is going to be July 20th on the topic of post-acute care, and it's going to be titled The Post-Acute Care Quandary, How to Find Alignment and Integration. Our special guest for that webinar will be Michelle Templin, who's Vice President for Strategic Business Development at Managed Healthcare Associates, and Sean Matheson of Levitt Partners. Together they offer decades of experience in post-acute care, and with so much happening in post-acute care in accountable care, this is certainly a webinar you won't want to miss. Now it's really a pleasure for me to introduce today's webinar. As I mentioned earlier, over the past several years, the ACO Learning Network has invested a lot of time and attention on strategies for incorporating pharmaceuticals and medication therapy management into the cost and quality equation in accountable care. Many of our members and many of the members who went from the Accountable Care Learning Network to the ACLC have been leaders in optimizing pharmaceuticals as a key strategy for reducing overall healthcare costs and improving the healthcare of their patients. Indeed, our two speakers today have been participants in the discussions with us from the beginning of our network discussions, so we're really delighted to have them with us. Our first speaker is Dr. Bobby Dubois. He's Chief Science Officer and Executive Vice President of the National Pharmaceutical Council, NPC. In this role, he oversees NPC's research on policy issues related to the appropriate role of real-world evidence in decision-making, how best to determine value in healthcare services, the relationship between access and health outcomes, and approaches to maintain an environment supportive of innovation. He's co-founded and led various healthcare research organizations in developing quality research with practical applications. Most recently, he was Chief Medical Officer at Cerner Life Sciences. He also co-founded Protocare Sciences and was its Executive Vice President, Chief Medical Officer, and later its CEO. Dr. Dubois is board-certified in internal medicine and brings more than 25 years of experience in healthcare research. Amanda Brummel serves as Director of Clinical Ambulatory Pharmacy Services at Fairview Health. Dr. Brummel has been employed by Fairview Pharmacy Services since 1999, when she graduated from the University of Minnesota. While at Fairview, she's built and practiced medication therapy management in multiple clinical locations. She was clinical supervisor for the MTM department, the MTM operations and program manager, and currently Dr. Brummel has responsibility for the MTM program, the clinical development and integration of pharmacy services in the Fairview Health Network, including transitions of care and the approach to transitions of care in the retail clinical services. It's a real pleasure to be with both Bobby and Amanda. We're going to begin with a brief presentation by Dr. Dubois, and then we're going to turn it over to Dr. Brummel to share the continuing successes that she is enjoying at Fairview. Then if we have time, we'll take some questions from the audience to wrap up the discussion. So without further ado, I'd like to turn it over to my friend, Bobby Dubois.
Thank you, Larry, and thank you for the opportunity to share the work that we're doing. I will provide a sort of bird's eye view of lots of different topics related to medications and accountable care and how the success of one is directly related to the success of the other. Amanda is going to give a view from the trenches of what it's like to apply some of the principles that I'll share in an actual environment, and what are the lessons learned, scars received, and opportunities for the rest of you to perhaps incorporate some of them as you move forward in your particular environments. Next slide, please. We got involved in this space a couple of years ago, and as everybody knows, the transition between fee-for-service and a value-based environment really does change incentives. It changes how we think about population health, and hopefully brings together a more harmonious view of cost and quality. And rather than being sort of competing with each other in a more fee-for-service world sometimes, hopefully they come together. And I think they come together very nicely when one thinks about medications and how they fit into success for the organization. If we go to the next slide, going back a few years, we began to wonder about all the things that are required to achieve success in an accountable care world. And you can see many of the items listed here, and for a lot of provider groups, especially physician-led ones, these are not necessarily in their core competency, reinsurance and various other things like that. But as we sat back and said, okay, there's a lot of things to worry about in terms of getting these organizations up and running and to get them to be successful, if you click one more with the slide, where do pharmaceuticals fit into all of this? And when we got started, folks said, yes, I think that's a quite important topic, but we have so many other fish to fry, we haven't begun to worry about this yet. So a couple of years ago, in the next slide, 3 organizations came together to begin to worry about it, to begin to get some ideas out on the table for others to react to. And then that partnership has led to some primary research, some best practices assessment, and we're very excited about sort of the cycle of innovation and expansion of that over the years. And the 3 organizations, one is ours, which is the National Pharmaceutical Council, which is a policy research shop in the D.C. area, the American Medical Group Association, and Premier. And we felt that we had both the pharmaceutical representation, the clinic representation, the hospital institution representation, and we really began to say, if you had an opportunity to think about the big picture as well as the more narrow picture of medications, what would that look like, and how can we bring this all together in a productive way? In the next slide, we identified really 4 different sets of activities, and I'm going to gallop us through some of those and then pause a little bit to give some actual data from what we learned and what remains to be done. So we began with a framework, which is, as you think about medications, as you think about success for patients and the organization, how should you bring those 2 together? And so over the next couple of slides, I'll be walking through that. The next activity we've done is to assess how ready organizations are to manage medications. So yes, medications may be very important. There may be various things one would like to be able to do. Where were we of the ACO community on that learning curve? And so we did an assessment a few years ago. I'll share the results with you. They were not all that optimistic. A lot of organizations really had a lot of gaps. And we now have the version 2.0 where we are reassessing readiness, and we'll have some data to share with you today on that. Well, once you've done your readiness assessment, it's pretty obvious that there will be gaps, and once those gaps were identified, the next piece of the puzzle was, could we develop some tools? Are there organizations already out there across the country who have succeeded in addressing some of those gaps? And then how can that learning be multiplied and shared with others around the country? In the next slide is briefly work that we've done and published in the American Journal of Managed Care on a conceptual framework. And we've got two different diseases here to sort of convey that. Imagine congestive heart failure as the perfect storm in a positive way. With congestive heart failure, you have drugs that by and large are relatively inexpensive. And if they are used correctly, you can avoid a very expensive part of the episode, which is hospitalization. So if you manage medications well, you reduce your overall costs. It's a perfect storm in a positive way. And in addition, for ACOs, one of the quality measures pertains to congestive heart failure. So if you do well, not only do you reduce your costs, but your ability to achieve the bonuses built around the quality achievement is more likely. So it's a wonderful scenario. Everybody wins. Everybody's marching in the same direction. In contrast, rheumatoid arthritis has a very different cost, quality, and trade-off story. Here, unlike heart failure, rheumatoid arthritis, the medications are the lion's share of the treatment episode cost. And there are not really near-term offsets. So unlike congestive heart failure, where good medication management lowers overall costs, good rheumatoid arthritis management won't necessarily reduce costs. And in fact, if you improve adherence, your costs might actually go up. In addition, there are no quality measures in routine use as part of accountable care. So now we've created a perfect storm in the wrong direction, where the expenditures of the medications and the proper management of those might increase costs, and there are no quality measures if folks try to economize and use less of these expensive medications. So this framework helped us to begin to wrestle with what are the opportunities out there, and one of the take-home messages from the article was that one size doesn't fit all. When you think about medications and how best to manage them, diseases like heart failure have a different story and set of incentives than rheumatoid arthritis. So that was kind of step one. The next piece of the puzzle, and the next slide, was again to assess readiness. So medications are important. If you look at the ACO MSSP quality measures of the 33 or so, almost half of them are either directly related to medications or indirectly related to medications. So doing well for the organization and the patients is going to be very much dependent on doing well with medications. So how well were organizations a couple of years ago in their ability to do that? So in the next slide, we conducted an audit, a survey, a combination of the two, to ask the question, where were organizations? Well, to figure out how ready they were required us to come up with criteria for what ready would look like. So things like, if you're going to manage medications well, electronic transmission of prescriptions would be important. Combining medical and pharmacy data would be very important. Things like medication reconciliation would be important, and things like that. So of course, if you're going to assess readiness, you need to have your criteria. We then, on the next slide, circulated that to 46 different ACOs back in 2013. So this is a few years ago. And what we learned was, of the 15 or so criteria, the majority of these ACOs were not really ready to do optimal medication management. Yes, a lot of them were transmitting prescriptions electronically. A lot of them did, in fact, have prescription and medical data in one system. But when you think about some of the other things which are very important, like are pharmacists involved in a deep way clinically, or are you able to notify the primary care doctor when the patient either does or doesn't pick up their medication? Are you able to understand what the offsets are of providing good medication management? A number of these things, only 10, 20, or 30% of the organizations felt they were able to do this. So this kind of raised the opportunity of lots of gaps. Now, how can we help address some of those gaps? Before I begin to sort of walk you through some of the case studies of how we found organizations that are addressing some of those, and then Amanda will go into detail about the program on medication therapy management at Fairview, let me tell you some of the early findings of our reassessment. So if you go to the next slide. So we wanted to re-examine this issue. Okay, 2013, pretty new in the life cycle of the ACO world. Yes, there was a lot of gaps. Yes, folks were not all that ready to do an optimal job with medications. But it's been 3 years. It must have changed since then. Folks must be much better able to handle this. So we want to be able to document that and show how well people are doing. Well, in addition to trying to just duplicate what we did before, we wanted to ask some other interesting questions. If you go to the next slide, we wanted to ask another couple of questions, one of which, in addition to how well folks are doing, is there any correlation between medication success and overall organizational success? So did one relate to the other? So hypothetically or theoretically, and our hypothesis would be, if you do a good job managing medications, you will do well overall as an organization. So we wanted to explore whether there's any data to connect the two dots. Where we found that there were, in fact, continuing barriers, we wanted to dig a little bit deeper and find out, well, why are those barriers continuing, and are there any insights about how to solve them? So we had a somewhat broader purview of research questions, and let me give you just a peek at the data. We're not done yet, but you can get a peek at some of the early data. So the next slide shows that, in fact, for some of these measures, there was a correlation between doing well from a medication standpoint and doing well from an organizational one overall. So if you look at the two different colors, the red corresponds to the overall organization doing well financially, and those organizations that did well financially have red dots, and those that did not do so well have blue dots. And then we ask the question, how did the successful ones do relative to the unsuccessful ones do relative to some of these elements of medication management? So in the first one, can physicians access integrated medical and pharmacy data? Obviously, it would be a good thing to be able to do if you're trying to do good medication management and population health. It may well be that an organization, in fact, has combined data, but that doesn't necessarily mean the doctor at the bedside can access that information. And you can see that on a scale of 1 to 10, 0 to 10, in terms of readiness, the high number is good, the low number is bad, that the organizations that were doing better from a medication standpoint did better overall from a financial standpoint. Second data point is pharmacists being engaged in care, and specifically their ability to examine an integrated data source. Again, there was a distinction. Was there an ability to have patient-reported outcomes? Again, a distinction. So you can see for these items, the hypothesis was met that doing well on the medication standpoint was correlated, doesn't mean it was causative, but it was correlated with the overall financial success of the organization. However, if you go to the next slide, like most research projects, it doesn't always come out the way you anticipate. So here are half a dozen areas where there was no difference in terms of medication readiness between those that were successful financially and those that were not. So if you look at the sort of the third to the last and the second to the last dots, here were the ability to notify the doctor when the patient was either taking their medicine or maybe it was discontinued by another doctor. You can see whether you were able to as an organization or not. It did not affect your financial performance. I would note that in both of those cases, the ability to do it was 5 on a scale of 10. So even those that were doing well or doing poorly financially, neither of them could actually do particularly well on this aspect. So maybe if there were organizations that were much, much better at the medication issue that you see listed, we might see the hypothetical correlation, but so far we haven't. Let's go to the next slide. As we learned in 2013, the majority of organizations did not do so well on medication management across the different criteria. And here what we're seeing are a whole series of data points, and you can see that the majority of the organizations were doing less than 7, meaning 7 on a scale of 10. We decided 7 and above was pretty good. Less than 7, you weren't doing so very good. And you can see the majority of the organizations, the vast majority of the organizations, were not doing well on the medication standpoint. So more work to be done. But when you sit back and you can either do one of two things, be depressed by the results. 3 years later, we're not doing all that much better from an organizational standpoint on medication management. But rather than being depressed, of course we were depressed, but in addition to being depressed, we asked the question, well, why is it we might not have seen more progress? Now, if you ask people without showing them data, well, why do you think these organizations didn't progress? Two of the obvious answers might be, well, we didn't have any money to do this, and to do this was really hard, you know, to get a pharmacist in the clinic and to do all these other kinds of wonderful things is expensive, and we don't have the money. Or the answer could be, well, we do have the budget, but we can't get everybody to agree on what to do. And it never, you know, rises high enough in the priority, even though we might have money. People are not all in agreement that this is a really important thing to do. So no sense confusing the discussion with data, but we're going to do it anyways. If you go to the next slide, what you can see is in a number of these areas, it actually was more a constraint, not of budget, but of getting people to agree. So if you look sort of midway down the path here, care pathways, which are one way of doing well with patients, doing well with medication management, and you can see that the red bar is that the biggest barrier was buy-in and not so much budget. So it was very interesting, and you can see the red bars in most cases exceed the blue bars, so more often than not it was getting buy-in, not just budget. So we found that either interesting, depressing, or a combination of the two. Okay, so let's look forward in a more optimistic way and say, well, in the next slide, maybe there are organizations out there. Yes, we were presenting data in a more aggregate level, but perhaps there's some individual organizations who actually are able to do some of these, and could they teach the rest of us about how we might do some of those things too, so when we redo the survey in a couple of years, everybody will be doing well. So if we go to the next slide, Amanda has been part of a working group with us and Premier and AMGA, bringing together ACOs who have actually succeeded in some of these areas. We have a half a dozen ACOs that are working with the organizations to share best practices and to learn from each other. We're publishing each of these case studies. Several of them are already published in the Journal of Managed Care and Specialty Pharmacy. They'll all be published there over time. And Amanda will go into in detail what she and her organization have done. But just to give you a flavor for some of them, they're all listed here, but I'll sort of briefly go through some of them. So the next slide is taking a drug safety alert program. This was the Marshfield Clinic, and as many of you know, the Marshfield Clinic is one of those that has done very well in a shared savings standpoint over the years and has been sort of well recognized in the media in that regard. And they had a pre-existing drug alert program. You know, patient with a certain age or certain comorbidity is placed on a certain drug, their creatinine is at a certain level, and an alert goes off. So they've had this infrastructure in place, and part of the reason they could do that is that they have a pretty ubiquitous electronic health record environment, and so for them this drug safety program was something they could put into place. But as they began to think more and more about the requirements of being a successful ACO, they said, wait a second, we could use this same infrastructure, the same group that agrees upon the alerts, the same IT backbone, and we could use this to flag quality measure problems so we could feed those back to the doctors on patient individual levels, and then just like a safety response, we could improve the quality measures, which then directly relate to the benchmark achievement and bonus payments accordingly. So that was one of the programs that we've written about and has been successful in that regard. The next example comes from the West Coast, San Diego and Sharp, where they said, wait a second, to be successful as an ACO, we're going to ask our primary care doctors to do population management, which means they've got more work to do every day. And there's only one, well, I guess there's two solutions. One is you work 24 hours a day, or two, you take something off their plate that doesn't require physician focus. And so Sharp said, you know, one way to deal with the added requirement on these primary care doctors is the medication refill process, which takes 30 minutes or so a day on average, and maybe we could centralize this process and have it done by pharmacists in a centralized location, and then the primary care doctor doesn't have to be involved on each and every case. Obviously, there are going to be circumstances where the primary care doctor does need to sign off on certain things, but in general, a pharmacist armed with an EHR, armed with a patient portal to the EHR where the patients can request the refills, this has been a successful program. It's being expanded greatly because everybody wants to save 30 minutes a day, and so this has been another one of the examples that's been published, and again, you can read about it if you so desire. The next example goes back to one of the points I raised earlier, which is buy-in, that you need to have buy-in almost more than you need to have a budget to get some of these programs and approaches up and running and maintained. So one of the articles that will be coming out shortly is about how do you get physician leadership to drive change in the medication sphere. Obviously, there's been a lot written about physician leadership in general in ACOs, but this will be the first article that specifically thinks about it from medication standpoint. And the American Medical Group Association has a program related to hypertension control, and obviously that is very intensively relying upon medications. And so this article walks through how physician leaders are important. Obviously, you've got your pharmacy program and you have your physicians, and you need to have them connecting, sharing data, being collaborative, and again, how did they accomplish this, and what are the lessons for that could be used in that regard. So the last example that I wanted to share is really one that I will turn over to Amanda, because it is her organization that put together this program, which was actually the first of the case studies we wrestled with and we published. I should point out that in many cases, a typical case study, one organization writes it, and it goes in the literature. People read it, others scratch their head, and they say, well, it's great that Amanda could do this, but there's no way we could do this at our environment. So in each of the case studies, we brought together the half a dozen ACOs who were not necessarily involved in that at all, and we asked them, how would you implement Amanda's program? How would you implement Sharp's program? What nuances, changes, challenges might be evident in your organization that weren't evident in the one doing the case study? And we thought that wraparound discussion would provide people better insights in how to do it. As well, the case studies also provide links to actual materials. So folks can say, well, yeah, I'd like to try it. Now, how do I actually, get the template of the reports or the training materials or whatever else it might be? So that's also been a part of what our activities have been. I'm happy to take any questions as part of the Q&A period, but I'll turn it over now to Amanda to walk through what they've accomplished at Fairview and what they've learned in the process.
Thank you, Bobby. Good afternoon, everyone, or I guess it's good morning some places. So if you want to go to the next slide, actually the next couple, you can go right ahead and get started. So just to give you a little bit of background on, who is Fairview and where are we? We are a large integrated health system that's located in Minnesota. We're centrally located around the Minneapolis-St. Paul area, and we've been around for a long time. We started back in 1906 and established as a nonprofit organization. We have 7 hospitals. We have over 45 primary care clinics and 55 specialty clinics. And we have over 30 comprehensive medication management practices, which is one of the areas that I'm going to talk to you about today with regards to our organization. Next slide, please. Thank you. So when, as a part of an ACO and looking at kind of where we wanted to go as an organization and what we wanted to do, a lot of this really turned into from managing patients on a daily basis, right, who were in front of us, to moving into more of a population health effort. And so really had some key areas of focus that we wanted to look at from an organizational standpoint. You can kind of see the triangle that I have on the slide as well, because, again, it was really looking at the interventions of our healthier population, those that were at risk or had a level of risk already that was rising, and then those that are high risk. And you'll see that as I talk about kind of the work that we've done in the pharmacy area, that really follows that pathway from our core population, our healthy population, to the highest risk patients. So a lot of the things that, Bobby mentioned in their discussions with ACOs and the things that they found was really, again, looking at the identification of those patients, looking at those evidence-based models, so we were having consistency with our treatment plans, and really looking at the most appropriate setting for the patient. So where could they be seen and what care team members could care for them in that way. Next slide. So this is really a picture of our clinic care team, just to kind of give that overview. We have pharmacists that are a part of the team. We have care coordinators, primary care. We have health coaches that we have employed within our system, diabetes educators, RNs, and this is really a snapshot mostly of our outpatient teams that you see in our clinic, but a variety of care team members that are there to take care of the patient. Next slide. This next slide is going to really help to organize or take a look at what our pharmacy services are. And I think that this will be important as we start to talk about the spectrum of how we care for the population, to just get a feel of how robust our pharmacy services are within our organization. So I think that is one of the key indicators of why we were so readily able to advance our practices into the ACO, and had a lot of the services available for our patients already. And I like to say we sort of have every flavor, I feel like, of pharmacy outside of nuclear medicine underneath our organization. So I'm not going to kind of go through the list, but you can see that there, that we have a lot of variety taking care of our patients for any need that they have from birth to death, really, from a pharmacy standpoint as well. Go ahead to the next slide, please. So when looking at that, that really helped us to, again, kind of go back to that triangle and say, what are we going to do from a population health approach, and how are we going to look at how pharmacy services really integrate into this work? And so I'm going to go through each of these key areas of some of the interventions. So there's a lot of other things that you may have seen there, the home infusion, other things that I'm not going to necessarily highlight today, but these are some of the key areas that we've looked at from a population standpoint, but know that there are lots of other things happening in the organization, and we will spend a little bit of time just looking at this from a patient view and how they can touch all the different parts as well. So next slide. We'll first start with our comprehensive medication management services, and this was the work that was really highlighted in the article that Bobby referenced. It's really our comprehensive approach and holistic approach to medication management. We look, when we see patients, we have about 24 pharmacists in those 30 sites. They meet with patients one-on-one in a clinic visit, so the patient comes in just like they would to see their provider, and we go through all of their medications to make sure that they're indicated, that they're effective, that they're safe and convenient for the patient. And we work with the primary care provider. We have a plan of care that we create, and we follow up. So we really manage these patients long term, and we have lots of collaborative agreements that we're able to make medication changes and adjustments. And so when we think about this service and how holistic it is, but also how much effort that it takes on the pharmacist standpoint for this service, we really look at this and say this is for our most complex patients. So these are for patients who have multiple conditions, who are not at goal, who have a high risk, who many times the physicians or providers have identified that they would really benefit from having a pharmacist really embedded into that care team. We also look at this from a lot of our quality metrics and the metrics that we are looking at to show the quality improvement in our populations. And I put some example impact areas here because I think these are some of the key areas that when we're looking at those metrics that we know that pharmacy is impacting. If you go to the next slide, we'll talk about kind of the continuum of care services with these patients. And so it's in this area, everybody, right, is dealing with transitions of care and how we manage our patients better during those care transitions. And so we really looked at this and said, both from our inpatient teams and our outpatient teams, how are we going to work better together? And what do we do to help improve our patients' medication needs? So we built teams across both, have referral systems in place for the hospital to be able to refer to the outpatient setting and communication back. We have identification of those that are in the hospital that would require or benefit from a pharmacist seeing them when they're inpatient as well, and really set up structure around that so that we can do better med reconciliation, better do med teaching for those high-risk patients, and then follow those patients after they get back to home to make sure that nothing is falling through the cracks or they understand what medications they should be taking. And so it is really our comprehensive medication management team that I just talked about that does the majority of that post-hospital follow-up with these patients. But again, a lot of other impact areas that we have here looking at that care transition and how we're managing that population. The next slide that I'm going to go into and talk about is really a lot of what also was highlighted with the Marshfield Clinic we really look at that as the medication utilization and our gaps in care and safety. So it's really, in my mind, using data to look at opportunities for improvement within our patient populations. So we have utilized this to look for brand to generic opportunities and things that we would want to change there within our populations, safety alerts that we would want to employ within our populations, high-risk medications, again, from a safety standpoint that we may want to identify and work with, and other best practice algorithms. So, heart failure, I have outlined as an impact area that we would scan our population and say who's not on an ACE or ARB and what do we do. And we can feed that data back to the clinic if it's appropriate for the clinic to take that over, or we can have our pharmacist team intervene on that. But again, it's really kind of taking that larger standard approach, and I think that's key when you're starting to care for this from a population standpoint. And then the next area that we're going to outline is our medication and disease, more of our therapy management. So the difference with this from our comprehensive approach is that comprehensive approach is looking again at that whole patient. In our medication and disease therapy, it's not that they're not looking what other medications that someone's on, but they're really focusing in on a key area that patient has a need for. So we have a large specialty pharmacy here at Fairview, and a lot of our patients who are on specialty therapies will participate in our therapy management program. They will be outreached to by the pharmacist so that they can, again, understand the medication that they're taking, understand how to administer it, and that we can follow up with them to make sure that they're able to take their therapy and are able to complete therapy with that. So we have programs. These are just a few that I outlined from a specialty standpoint, but then we also really do this in our general population, and a lot of times, the Coumadin clinics and anticoagulation clinics have been around for a long time, but it is really that focusing on that therapy. So that's another example. We have an anemia clinic as well that we do that. And so we have some impact areas, again, that you see that are really focused on some of those key areas, but we have teams that are working on that. And the other thing I want to point out here is all this is very fluid, right? So we may have a patient who is enrolled in the therapy management program, and then the pharmacist identifies, wow, there's a lot going on with this patient. Things are not in control. I'm going to refer them into the comprehensive medication management program, and so then those pharmacists will work together in that handoff, and we'll be able to take care of that patient more comprehensively, get things under control, and we may hand that back off then to the therapy management pharmacist. So this is a fluid path for the patient. And then finally, I'm going to talk just about some of the community pharmacy services that we provide. So we do have over 30 retail or community pharmacies. They are primarily attached to our clinics and so are embedded right into our care teams as well within that. And we do a variety of clinical services there as well. So we do hypertension management where any patient can come in and get their blood pressure checked and managed through that. Asthma programs, of course, adherence programs, vaccinations. So again, much more of a population-based touch there. With that you're looking more broadly. So hopefully I've taken you from the top of the triangle to the bottom of the triangle at a high level of kind of the different interventions and services that we have employed and initiated within our practices. And then if we go to the next slide, I really like this, just looking at this from the view of a patient and kind of looking at that full spectrum. So you can see all of the different services that are there and really the work that goes into treating our patients. So a lot of what we have built in the infrastructure so that patients can get their care within the care system, that it can be coordinated, and it can, everyone is seen again as a part of that care team so that we all are sharing that same information, that everything is more seamless for the patient, and that we have better communication with family and the rest of the care team members. So lots of different areas that our pharmacy program can touch within a patient. And with that, I'll turn that back over for our question and answer.
Amanda, thank you very much. That was a great presentation, and Bobby, thank you as well. It's always great to see new research coming out on these topics. Just a couple questions. I invite all participants to submit questions. You can submit them to the queue. I don't see any right now, but so I'm going to go ahead and ask a couple that I had. Great research, Bobby. I was just curious. Your slide on buy-in versus budget. It seems to me that if you don't have the budget, you're not going to get it without buy-in. And frankly, even if you do have the budget, if you don't have the buy-in, you're going to get a lot of questions. So I focus more on the buy-in. Can you tell us any indications on how to really attack that problem with buy-in? Is it a lack of evidence, or is it just apathy within the or lack of understanding within the ACO?
That's sort of the billion-dollar question of how to get buy-in, and I think there is no single answer. I look forward to hearing Amanda's view. One aspect is having a very savvy medical director, someone who knows how to work with groups is one piece of the puzzle. Another piece of the puzzle is to actually find people who might be your naysayers and turn them into champions. If you can get people who tend to be skeptical on board, then they often can attract a lot of other people to the same idea. That's the second piece of the puzzle. The third piece of the puzzle is sort of what's the culture historically. It's one thing to have an environment like a Kaiser or some of these integrated medical groups where there's been a sort of history of kind of working together as teams. I think that's a different challenge. It's much less of a challenge to get buy-in than in situations where you're sort of coming together for the first time. Another piece of the puzzle is sort of the split or siloing of pharmacy versus everything else. And in some organizations, those are rather disparate entities, and even can be to the sort of in the worst case scenario where, you know, one set of pharmacies in charge of sort of the oral medications, the Part D type medications, and others in charge of the injectable or infused ones. And then you have the sort of medical side of the house, because a lot of the medication management activities do require trust between the pharmacist and the primary care or specialty doctor. As Amanda alluded to, you need to have practice agreements between pharmacy and medical to say, okay, under these circumstances, the pharmacist should feel free to adjust the dose, to add certain other medications, and does not need to get buy-in on an individual patient basis from the doctor who's the primary care doctor. But if you don't have those practice agreements in place, it's a whole host of other challenges, and it's a lot less efficient. Amanda, other things you might add to the issue of getting buy-in?
Yeah, I think the few things that come to mind, I think you're right on with having a champion. I mean, I think that we have done some research, and there's also many studies that we've done that I would just put in the plug of. If you go to fairviewtm.org, you can kind of see those that are there. But we did a group of case studies with other systems in Minnesota looking at why was it successful, what made this successful of having pharmacist integration. And time again, I mean, having champions were a huge piece of that, someone recognizing that. I would also say on the pharmacy side, it really is on the pharmacy, you know, and pharmacists understanding and embracing what their role can be in this management. So, you know, understanding the quality landscape, understanding quality metrics that are being measured, showing how pharmacy can be a part of that, and having those conversations with the medical team. I think right now a lot of those conversations continue to stay in the pharmacy teams, and they don't necessarily always make it into the medical teams, and that's really unfortunate, because I really think once you start to talk to the medical teams, they understand, they get what can there, and there's all these things like, Bobby talked about collaborative agreements and other things that can help to augment that. I think another key thing sometimes to recognize is a lot of our ACOs have started out of Medicare, and a lot of the Medicare pharmacy spend has not been included within the total cost of care from an ACO standpoint. And so I often don't see that or find that in the private space, but I've seen that more. And so I think, again, it just got put a little bit more on the back burner as people were trying to get, becoming an ACO figured out, that it wasn't there, and they haven't always seen that correlation of how really managing the medications is such a big key in the toolbox. And so, I was a little disheartened, Bobby, with your with your research, not necessarily showing that as strongly, but I still believe that it's there. It's just hard to get teased out.
Thanks, Amanda. Amanda, I want to drill down a little bit. You mentioned your specialty pharmacists or your specialty pharmacies and just how key the outreach is, and we can all see that. And indeed, on the community pharmacies, the 30 that you have, you talked about how your clinicians are in touch with patients, and Medicare now is experimenting with new models and MTM and trying to tease out what are those most effective interventions. Do you have any new insights on effectiveness of interventions and things that have worked particularly well at Fairview with specialty and or clinical community pharmacy?
Yeah, I think that's a great question, and one we asked ourselves. We did all of this and said, we really feel that we're making a difference. We have a lot of individual case studies that we have done that have shown that, and we've probably had our strongest research be in our comprehensive medication management program. So we actually just have expanded and have created an outcomes department within our pharmacy structure to answer those same questions. So I don't have any definitive data that I can say, has gone through research rigor yet, other than we have begun to look at our programs, like for example, our blood pressure management, and it is strongly looking that when our pharmacists on the retail setting are involved in managing a patient's hypertension, that we have better outcomes in those patients than when they're just managed alone in the clinic. But we'll hopefully have more studies to share as the year continues and goes by. And again, we have a lot of case studies and stories from patients of the improvement in their care, and we can see that, but we really are doing the work now to be able to show that more robustly as well.
That's great. Thank you. I have one last question for both of you. As we started talking about this, we've got a lot of folks in the ACLC from the manufacturing community, and we know there are barriers, but what role can pharmaceutical manufacturers play in helping ACOs better integrate pharmaceuticals and medication therapy management into accountable care?
Yeah.
Go ahead, Amanda.
I was going to say, do you want to take that, Bobby, or do you want me to start? I would just say that we have done a fair amount of work, I think, with our pharma partners around our populations, and we actually actively hold a meeting every year. We just finished that up earlier this month, that we invite, I think we had over 200 representatives from different pharma companies to come in and learn about what we're doing. So we have our medical directors there and other folks from our pharmacy teams to show and talk about key areas that we're working on and that we would like to partner in. And then we, really kind of get proposals and ideas from other pharma companies so that we can talk about, is it a good fit, and really try to outline our key areas of approach. But we have done things like looking at our populations and studying different care team interventions. We looked at health coaching, for example, and looking to see if it was more effective face-to-face, telephonically, or if we could do it electronically via computer. to look at those types of interventions. We have had companies come in and help us do, areas that we knew from a quality standpoint our teams weren't adequately trained in, and helped us with that. We have also looked at just risk-sharing agreements as well within that, and kind of taking a look at all different types of opportunities, identifying different areas of need of using a medication, and if the total cost of care in the end would be less with that patient on their medication versus not being. So I think exploring lots of different avenues and partnerships in that area.
Great. Bobby, did you have some perspective on that?
I'll make a couple of points. I think there's sort of the historic types of interactions and then the new ones. The historic ones, pick a disease where a drug company has a lot of presence. It's diabetes, it's hypertension, it's multiple sclerosis, and then partner with an organization that's surrounded adherence issues or data analytics to understand how the patients progress through the care system. Those are the historic kind of very focused types of relationships between payers or provider entities and the pharmaceutical industry. I think where we're beginning to see things progress, certainly on the payer side, drug company perspective, is in the risk-sharing arena. So there's been a number of announcements recently with Harvard Pilgrim, which is a health plan, obviously, but also has provider entities underneath it. And they have a whole series of risk-sharing relationships now related to the PCSK9s, to Entresto, the new heart failure drug, and then most recently announced with Lilly for one of its diabetes agents. And I think what you'll begin to see are sort of broader relationships which aren't just as narrowly focused on either data analysis or specifically adherence, but have a purview that's greater, and the interactions and the connectivity between them and the shared successes are obviously much deeper when there's a full kind of double-sided risk-sharing type of relationship.
Thank you, and thank you both Bobby and Amanda for the insights and presentations today. Very rich content, and great to have you with us. We're about out of time. I wanted to let people know again, an audio recording for this conference call will be made available and will be included in our weekly news summary. Again, I wanted to mention that the next webinar will be July 20th, so mark your calendars. Once again, it's going to be on the topic of post-acute care, titled Post-Acute Care Quandary, How to Find Alignment and Integration. The presenters there will be Michelle Templin from the Managed Healthcare Associates and Sean Matheson from Levitt Partners. Again, together they are a great team for this topic, so please join us on July 20th. If you have any questions about the ACLC or follow-up questions on the webinar, please email us at members@accountablecarelc.org. Again, that's members@accountablecarelc.org. We'll be happy to address those questions. Again, I want to thank you all for joining us. We hope you found this presentation valuable, and we look forward, as always, to your feedback. Thanks again, and have a great afternoon.